Okay, well, we should get started because we've got a lot to cover and not a lot of time. So good afternoon, everyone, and welcome to our Palliative Care ECHO Lunch and Learn series. My name is May Remenda, and I'm a knowledge broker at the Center for Education and Research on Aging and Health at Lakehead University. I know that's quite the mouthful, so we lovingly refer to our center as SARA. SARA coordinates the ECHO sessions for the Northwest Regional Palliative Care Program and St. Joseph's Care Group hub site, which is part of the National ECHO Project led by Pallium. Today's session is titled Supporting Vulnerable Patients Who Could Benefit from an Equity-Informed Palliative Approach to Care. This is a very special session to me, as I've had the privilege to work alongside our amazing presenters today, and I've witnessed firsthand some of the incredible work that they do. I will get to their introductions momentarily, but we've got a few more things to cover. So here's a little bit about the Palliative Care ECHO Project, if you're not familiar with it. It's a 5-year national initiative aimed at cultivating communities of practice to establish ongoing professional development among healthcare providers who care for people who could benefit from a palliative approach to care. If you visit Pallium Canada's ECHO website, you will find tons of different ECHO session opportunities on various topics, all of which are free of charge. I'd also like to thank Health Canada for the financial contribution to this project. With that said, the views expressed herein do not necessarily represent the views of Health Canada. And while we are joining each other virtually, as the host of the session, Lakehead University respectfully acknowledges its campuses are located on the traditional lands of the Indigenous people. Lakehead Thunder Bay is located on the traditional lands of the Fort William First Nation, signatory to the Robinson Superior Treaty of 1850. Lakehead University acknowledges the history that many nations hold in the areas around our campuses and is committed to a relationship with First Nations, Métis, and Inuit based on the principles of mutual trust, respect, reciprocity, and collaboration in the spirit of reconciliation. As a center, we are committed to working towards reconciliation and decolonizing our work, and have committed our, as a staff, to educating ourselves in these areas, both personally and professionally. With that said, we would love to know a little bit about you as well. So please feel free to introduce yourselves in the chat, what your role is and where you're joining us from. And we will go over a few more things before we get to the session. In terms of housekeeping, just a few reminders. Please keep your microphones on mute unless you are asking a question. I am going to record the session today. And then in terms of question and answer period, we would love to hear your questions, but if you could save them until after the speakers are done, that would be wonderful. You can add them in the chat and I can bring those forward for you, or you can also raise your virtual hand and speak if you would like to. After the session ends, an evaluation survey will pop up, and we would greatly appreciate it if you could complete that for us, as it helps us inform our future webinars and events. And now finally, we are on to the introductions. So Brittany D'Angelo is the manager of Palliative Care Link and Safer Supply at Norwest Community Health Centers. Brittany has spent time working as a frontline paramedic, a community paramedic with a palliative care scope of practice, and as a policy consultant for the Canadian Public Health Association. Brittany has developed a passion for health equity and social justice that she uses to develop new models of care aimed at increasing access for marginalized populations. When not at work, you can find Brittany enjoying the outdoors with her partner and her dog. Julie is a palliative care harm reduction support worker at Norwest Community Health Centers. Julie was born and raised in Thunder Bay and is a mother of 3. Julie has been working with the city's most vulnerable for the last 7 years at Shelter House and Norwest Community Health Centers. She is also a facilitator of the St. Elizabeth's curriculum on palliative care for frontline workers for Hospice Northwest. And in her spare time, Julie is an active member of Thunder Bay's recovery community and enjoys staying active. And Natalie is the nurse navigator for Palliative Care Link at Norwest Community Health Centers. Natalie has been working as an RN for over 21 years in a variety of nursing roles. Prior to starting at Norwest, she worked 5 years as a palliative care nurse with home care. And when not at work, Natalie likes to be outdoors or spending time with her family. And now with that, I'm going to quit talking and I'm going to stop sharing my screen to pass it on to Brittany and our presenters. So please welcome them.
Awesome. Thank you, May. I'm just going to take a second here to make sure that I am set up. May, you're the only one I can see. Let me know I'm in presenter mode. Awesome. Okay, so thank you everyone for joining us today, and thank you, May, for the wonderful introduction. So as you know, we're here today to talk about supporting vulnerable patients who could benefit from an equity-informed palliative approach to care. So our few learning objectives for today, we're going to explore what it means to take an equity-oriented approach to care. We're going to review the concepts of harm reduction, trauma-informed care, and culturally safer care as they pertain to a palliative approach to care. And we're going to identify some of the barriers to care and resources for palliative and vulnerably housed clients here in Thunder Bay. So we like to open up with this quote. I actually heard Dr. D'Angelo speak before I even worked in the palliative care world. And if you don't know who he is the physician that leads the PEACH team in Toronto that provides similar work to our team here in Thunder Bay for those that are vulnerably housed and are homeless and or using substances that have a diagnosis of a life-limiting illness. And you see this when you're out on the street, you see the reality of it, but he says that homelessness is a life-limiting illness. Homelessness is a terminal diagnosis. So let's talk a little bit about what makes Canadians sick, and so that we can understand why it is that our clients are sicker than the average. So we know that 50% of influences on health are caused by the things that we call the social determinants of health. So these are things that are outside a person's own individual agency to control. So those can be things like education, social exclusion, gender, being Indigenous, your housing status, but only 25% of our health is actually determined by our access to the healthcare system. And we know that the social determinants of health impact somebody's access to the system and how accessible our services actually are to them. And then only 15% is from our biology, so the things that our parents pass down to us, and 10% is from our environment, which we know that folks that don't have a home are exposed to harsher environmental conditions than those of us that have shelter over our heads. So what is the difference between equality and equity? I think this is a great visual representation. You've probably seen it before because it's so good. Equality is giving everyone the exact same resource and assuming that will lead to equal outcomes. Whereas equity is the understanding that some people start from a place of greater need and therefore require different supports in order to achieve the same outcomes. So this would kind of be like giving every cancer patient an appointment with an oncologist and assuming that they're both going to have the exact same outcome from that appointment. But someone that's from a middle-class family that has a vehicle and a loved one to drive them to that appointment, has a cell phone to receive their appointment reminder, is likely going to make it to that appointment and benefit from it. Whereas somebody living on their streets would require much more support in order to be able to make it to that appointment, never mind being able to implement the care plan that they're given from that appointment. So we know that homelessness has a negative impact on health, but it's important to note that this relationship is bidirectional. So by that, I mean it goes both ways. Homelessness can have a direct impact on health through the physical environment someone is exposed to, or by making it more difficult for them to access healthcare and adhere to medical recommendations. But on the flip side, health status can also contribute to homelessness. So as somebody that is living in poverty becomes more and more sick and less likely to navigate through the health and social systems or able to provide for themselves, they're more likely to become homeless. And among our homeless population, we know that we see an increased risk of premature chronic diseases, infectious diseases, nutritional deficiencies, mental health struggles, and substance use. And shockingly, the life expectancy among this population is only 40 to 49 years old, compared to 81 years old for the general population. So that really does bring us back to Dr. D'Angelo's quote that homelessness is a life-limiting illness. So 1 second here, I'm going to... Oh, I muted myself and then started talking. Go ahead, Natalie.
We want to take some time to set the stage for our presentation with a video we made capturing interviews that we did with some of our clients and some of our coworkers.
This is one of the projects that May worked on us with. We had the privilege for help to make this. So thank you, May, for that. And if you could just confirm once I start that my sound is as well.
What was your living situation when you first found out about your cancer diagnosis?
I was homeless.
And where were you living?
In the bushes in Westport, on the bay. When I turned 65, I couldn't afford my rent anymore. And yeah, I had to leave where I was. I couldn't find another place. Stayed at a buddy's place, another friend's place, couched there for a little while. And that turned into a shit show. And the drugs were still involved a little bit in my life at that time. And I wanted out of that lifestyle so bad. So I ended up finally on the streets. And I found a nice little place in Westport. And I was there for a long time.
Go to the hospital, waited 12 hours to get seen just because you're an alcoholic or drunk, you know? They always think that you're abusing it. Just want to come and get medicine. I don't know, sucks. But yeah, so what are you gonna do when you drink?
My name is Kevin Bezanson. I'm a palliative care physician based at the Regional Hospital and Cancer Center. Most of my work is with patients who have cancer and cancer that unfortunately is not curable. In many cases, unfortunately, being homeless creates just an inordinate number of barriers to actually getting the care that you need. When you are facing difficulty meeting your basic day-to-day needs, and then on top of that, you have a serious diagnosis that is impacting your ability to function at all. The idea of trying to manage those kinds of difficulties, pain, nausea, frankly, difficulties with your bowels or other things on the street is hard for me to even imagine trying to do. They're difficult needs to meet in a system that's really stressed.
So I'm Veronica Proper. I'm a nurse practitioner. Most of the folks that I take care of are struggling on a daily basis just to survive. So even things that, I take for granted, like a nice warm spot to sleep that's dry and a place where I feel safe to call home, trying to find that sometimes is very challenging for people. The day in the life is spent surviving.
When you're homeless dealing with this shit, you don't deal with it. You focus all day just on surviving and food and getting around. And then, of course, you end up with the wrong crowd and it goes all over the place. So you have no time to focus on cancer. Wasn't even on my radar screen.
My name's Julie Diner, and I work at Norwest Community Health Centers. I was also homeless and pretty sick. So I actually feel I can connect with people that are in that situation. It's good to have someone with lived experience to be working with folks. They're not gonna trust you. They're not gonna trust the nurse that's in the emergency. They're not gonna trust the doctor, but they might trust me or someone like me who's actually been there. Because I can say to them, you know what? I slept on that mat before, or I know what it's like to wake up and just need a drink or a fix. I know what it's like. So people trust me. Have you experienced discrimination and racism in the healthcare?
Yes, of course I have. The way they look at you, yeah, it's a dirty Indian. Yeah, that's the words that is still getting used from us. Yeah, a drunk Indian, dirty Indian. Yeah.
People are saying that to you still?
Yep. Yeah, that's the racism part, Yeah, it's not a human being. Yeah. cruel. It can be really cruel out there.
So many folks are judged because of their addiction / mental health. They're treated differently. It's so obvious. I mean, everybody knows it. Everybody knows that they're treated differently. But everybody just turns a blind eye, really. That's what I see. People just turning away.
I mean, I think for many of these folks, they've had very difficult experiences with the healthcare system, often, traumatizing in some cases, experiences with the healthcare system. So there are often deep issues of trust and being able to seek care in the first place.
The reason that these folks don't trust you is not because of you, but it's because of the system, and it's because of their past and past experiences.
Sometimes what we see is people who insist on staying in a shelter past the point really where the shelter can manage their care, because that's where they feel safest. That's where they feel okay to try and meet their needs. A place where they feel safe enough that they go, okay, I can actually lay down on this mattress on the floor and I actually feel like I can close my eyes for a bit because I know that this is a safe spot. Nobody's gonna harm me, or nobody's going to take my things, that kind of stuff.
We also, for sure, see an overrepresentation of folks who are struggling with addiction. And frankly, that makes the kind of care we deliver in terms of trying to deal with pain and other issues more complicated. How to do that safely, how to do that in a supported way, how to do that in a way that doesn't increase harm, but make sure that people's needs are met.
Doctors want you to go to this place, but if you haven't done your income tax and you don't have your ID, you can't get there.
How do you dispatch a home care provider to someone who doesn't have a home? It's a bit hard to send somebody to an encampment space and say, well, you're looking for the tent that's blue, with the little flag out the front. I mean, that maybe that's valid, or maybe that tent has moved now because that place didn't feel safe. There's a lot of moving parts quite often, which represent barriers for people.
Sometimes I'm almost at the point where you give up, because I don't sell drugs, I don't do drugs, I don't drink. I have cancer, my expenses are high, and I'm broke as fuck all the time. What in the hell? I was never broke. Last summer I was never broke. Riding the mountain bike up and down the back country roads and across the city. I can't do any of that anymore. So even when I need food or something, it's like you always have to ask, and I'm not one that asks for handouts. I try not to.
For me, this work is really about trying to find a way in to making sure that those folks get something approximating the kind of care we would want everybody to have. And if we don't do something differently, if we don't do something extra, then we are not going to achieve that, because these folks need a different approach than, in many cases, than the sort of mainstream population.
What do you need right now?
Oh. Gosh, I have no idea. But I'd like to volunteer and help other cancer patients. That's what I'd like to do, because I've been through this in a short period of time. I would love to help, drive around and talk to people and help. That would be awesome. That would make me so, I could love that.
My life, I would like to be 109.
We need to be flexible and just be creative. The traditional, pick up the phone and make an appointment and call somebody and they get their own ride here. So that doesn't necessarily work for this population, and that's okay. There's ways to work around it.
I think it changes when we model something different. I think this is where having some additional focused resources and consistency of providers can make a big difference.
Every single person deserves to live and die how we want to. And if we had a designated team for people who had palliative diagnoses, who are vulnerably housed or homeless, we'd be able to do that. We'd be able to meet the people where they're at.
And I think that's what this team is about recognizing that wherever people are, if they're on the street, if they're in the hospital, if they're in a clinic, that we're trying to be there to the extent that they want us there to support the care that they need, and just keep showing up. If we say that, everybody is important, everybody should get equitable care, and I think that is a tenet of our system, then folks who have more needs need more care.
We need to understand that folks that are homeless or addicted or have substance use disorder are humans and people just like you and I. They deserve to die with dignity. They deserve to die the way they want to. They've suffered so much in their lives that they shouldn't have to suffer at the end.
Now that we have had our heartstrings pulled on, let's talk about who normally accesses palliative care. These are often individuals who are diagnosed with cancer, have predictable trajectories, come from dominant social groups, have strong family or community connections, and have stable housing. But many people fall outside of this demographic, such as those who are experiencing homelessness, poverty, mental illness, individuals who use substances, and folks with stigmatized diseases such as HIV, AIDS, and Hep C. We're asking you to take a hard look at this picture. This patient appears to have multiple supports, a roof over his head, and a clean and safe environment, to name a few. The clients that we see do not have this. Our people need more.
Okay, so in 2019, our colleagues from the Palliative Outreach Resource Team in Victoria, BC, did a study on barriers to care that the homeless population experiences. And over 2 years, they did 300 observations with 25 clients and an additional 147 interviews with clients, support persons, and providers. And they came up with 5 main themes of barriers this population is experiencing. The first is the survival imperative. So when access to immediate needs like shelter and food are lacking, accessing palliative care is not a priority to this population. And this can be further complicated by addiction, where we often see the need to supply their addiction being prioritized over things like food and shelter, never mind their palliative needs. And when the priority of meeting their basic needs are not recognized by service providers, these patients experience amplified vulnerability as they become more and more ill and unable to physically seek out their daily needs. The second theme is the normalization of death. So individuals that come from social disadvantaged environments, unfortunately, witness many people in their peer networks dying. And this is especially true during our time of the opioid epidemic that we're all in. And they've also been told many times throughout their life that they're going to quote unquote die from their lifestyle. So this normalization of death tends to make end-of-life conversations less serious or significant for those individuals. And that's something that we need to recognize as providers when we're having those conversations. Third is the challenge of identifying individuals that could benefit from a palliative approach to care among this population, since the majority of their care is provided by workers outside of the formal medical system. So most of these patients end up being diagnosed late in their disease trajectory or not identified as someone that would benefit from our services until they're actively dying. Fourth is the difficulty of navigating multiple systems. So in order to have all of their needs met, these clients have to access the medical system, social assistance, shelter, housing, and food banks. And a lack of continuity of care is difficult for them. When they're kind of going in between these different systems, they can fall between the cracks. And that's especially difficult when they already have a lack of trust in providers in the system. So defined boundaries between the roles and responsibilities of health and social systems create these cracks where the client's needs often fall through. And the ability to navigate between these barriers becomes more challenging as patients become increasingly frail, in pain, and fatigued. And the last theme is that a lack of appropriate affordable housing and adequate housing means that clients often have to move as they have increasing needs at the end of life. And potentially if they begin to rely on the street drug supply for symptom management if we're not managing their pain and their symptoms. So risk management policies for home visiting nursing and a push in Canada towards more home deaths has led to less and less options for accessing palliative care services for community members without the privilege of housing or safe shelter.
That's me. Poverty is the huge overlying thing, and that just manifests in any number of ways. So it's as simple as food, telephone access, taxi rides, being able to buy support stockings, accessing a cane, getting to the Red Cross to pick up supplies, or navigating how to do that without a phone or without friends. Think about the last time you had a cold and you were cuddled in your bed and you slowly made your way to the kitchen to make your Lipton chicken noodle soup and a cup of tea. Now, can you imagine being palliative, in pain, tired and struggling with mobility issues, and then being homeless? There's no room at the shelter when you finally make it there and you're hungry and cold, you're experiencing withdrawal symptoms from the toxic street supply you've been accessing to cope, and you have no way to communicate with anyone and no social support. Sometimes we fail. Excuse me. Roxy lived at the shelter house for years on and off. Her family were the people on the street and the workers at the shelter house. Roxy was very sick. Her liver and kidneys were starting to fail. She knew she was dying and discussed this with staff at the shelter house. Her wishes were to die with her chosen family at shelter. We did not have the capacity to honor those wishes. And as her health worsened, she could no longer take care of herself. We had to send her to the hospital. She died a short time after alone. We were unable to meet her wishes. And Roxy's story is unfortunately not unique. And in the years since, I've seen many similar stories.
Thank you, Julie, for sharing that story. I think it highlights the need for us to learn and do better. So let's spin it around and talk about some of the ways in which we can improve. So first of all, we need to accept that in order to adequately serve these clients in a holistic way that palliative care claims to be, sometimes we need to step outside of the traditional boundaries of the medical system. So we need to be creative and innovative, and we need to remain dedicated to meeting their needs. I think Kevin Bezanson in the video said you just need to keep showing up. And we also need to adopt some new approaches to care. So the first of which is trauma and violence informed care. And that understands that past and ongoing interpersonal and structural violence leads to inequities and can lead to behavioral reactions. So the primary goal of this approach to care is to create a safe and trusting environment that actively tries not to re-traumatize clients. And it approaches behavioral reactions in a way that is empathetic and seeks to understand and adapt that individual client's needs. Second is harm reduction, which includes the practices that mitigate harms associated with drug use itself. It recognizes that stigma and discrimination create more harms than they do good. And importantly, in the palliative care world, harm reduction understands and accepts that individuals with a life-limiting illness and a history of substance use will continue to access the street supply if we do not adequately address their pain and withdrawal symptoms. And the last is culturally safer approaches to care. And this approach seeks to challenge discriminatory values and assumptions held within the healthcare system. It recognizes that providers must be culturally competent in providing care to their clients. And this is particularly important at end of life, where many cultures have significant beliefs and ceremonies. And we will share a document with you for continuing education on these subjects, because we don't have much time to talk about them today. But if you want to learn more, it is all online and self-directed learning. So we'll make sure that gets out to you.
Addressing basic needs. Something simple you can do is ask what the person needs. Do they have a way back to where they're staying? Do they have a place to stay? Do they have clothes that are appropriate for the weather? And if you can't help them with these things, don't just ignore it. Call someone who can help. Slow down and listen. Slow down and ask the person what they need and actually listen. Build some trust. Don't use big words. Everyone has a story, and many of the clients we work with don't have anyone who's ever stopped and listened. Let's talk about pain management. So this is a story about Laz. Laz was vulnerably housed for years and spent a lot of his time at shelter house. He came to use the safe injection site here at Norwest. He had been using substances for most of his life, and his body was starting to give up on him. He was dying. He ended up in the hospital a few times, and because of the hospital's zero tolerance for substance use, when Laz was caught with IV paraphernalia, he was punished when the doctors cut him off his pain medications. Laz eventually joined the Safer Supply program, where he had his primary needs met, a safer supply of opiates, thus minimizing risk of toxic fentanyl, in which he was overdosing regularly. He also had access to a non-judgmental nurse practitioner. Once Laz ended up in hospice, the Safer Supply prescriber worked with the palliative care docs to ensure he had proper pain management in his final days. His story differs from Roxy's, as he died with his pain managed and his wishes met.
Okay, so normally we're doing this presentation in person and I'm able to ask, are there any prescribers in the room? So I'm just going to go ahead and pretend that there is, because if there isn't, you are all advocates out there in the world and you're able to help address this as well. So maybe you can put in the chat if you do know what the normal starting dose of Dilaudid would be for a palliative care client. So let's say an 80-year-old woman with bone cancer. If you want to pop that in the chat, go ahead. And I'm going to do a little bit of medical math, so everyone hang in there with me. Most daily IV drug users are consuming around 1 point of fentanyl at a time, potentially 5 or more times a day. So let's say on the lower end, someone is using 5 points per day or 500 milligrams of fentanyl. We know that Dilaudid is only about 1/10 as strong as fentanyl. And we also know that an individual that's using opioids from the street is often using fentanyl that is potentially laced with even stronger opioids such as carfentanil or isotonatazine. So I'll use Safer Supply as an example because right now it's the only medical grade equivalent to the street supply that we can understand. A client with no chronic diseases on the Safer Supply program is on average using 100 to 120 milligrams of Dilaudid at a time, twice per day. So I don't know if anybody put anything in the chat there, but I would say most people, was there some guesses?
There is 0.5 milligrams every 2 hours as needed of hydromorphone.
Awesome, 0.5. So they're using 0.5 and we have Safer Supply clients with, and again, the caveat, no chronic diseases are using around 120 milligrams at a time because of how high their opioid tolerance is. So I'm not saying that 120 milligrams of Dilaudid is necessary for someone at the end of life. Metabolism comes into play, and so does protecting your medical license and all of our medical best practices. But if we know that a starting dose for an 80-year-old woman with bone cancer is that low, and that it's not adequate for touching the pain that somebody is experiencing if they have a tolerance to opioids, especially if they've been using our street supply. So it is even enough to come close to keeping them out of withdrawal symptoms, which are arguably just as painful, if not more painful, than some of the pain that we experience from life-limiting illness. So you combine that with palliative pain and withdrawal symptoms together, and we need to find a better way to provide pain management to this population.
So PACT, the Palliative Advocacy Care Team. There are 10 or more agencies working together. We conduct bi-weekly rounds, identifying clients and connecting them to the most appropriate resources. And we also meet bi-monthly for working group meetings. This is a group that meets every 2 weeks to discuss clients and navigate their care. Hospice Northwest, Norwest Community Health Centers, Delico Anishinaabe Family Care, Elevate Northwestern Ontario, GAPS, Home and Community Care Support Services, Palliative Care Associates, Superior North EMS, and the Emergency Department, various shelters as needs arrive. The bi-monthly group meets every 2 months to push the work forward, and since 2019, we have been utilizing the study done in Thunder Bay by Delico. There are 7 recommendations from this Delico study. The green indicates the work that is happening on a regular basis. Continued collaboration in the bi-weekly and bi-monthly meetings, increased access, and we do believe that through our work, the clients are getting treatments and care much better than they would have without. And as we are educating and intaking clients, we are educating them about their care and the system. Yellow are items we have plans to work on in the next year or so. In November of 2022, we applied and received money from Health Excellence Canada Our PACT team is one of 10 organizations in Canada that has been selected to come up with best practices to support the vulnerably housed at the end of their lives. We represent the PACT team in Thunder Bay at several meetings with Health Excellence Canada, where we are also learning from the other 9 communities. We are planning to take a bit of a longer version of this presentation to many and all healthcare providers that will have us. If you want us to come to your workplace and deliver this session, you can talk to us after. We are hoping that this presentation will help people understand more about this population and start to eliminate the stereotypes associated with our clients. The red items are more complex and require a longer-term approach. Next slide.
Julie, you're muted.
I saw that. Sorry, guys. So palliative care harm reduction support worker, that's me. In this role, I get to be boots on the ground and I connect providers with clients. I provide a trusting space and speak the same language as the clients because of my lived experience. Some of the things I can help with are ID. Housing is, I try really hard with that one, but there's not a lot around town. I can help with clothing, transportation to appointments, bus tickets. I accompany clients to their appointments and just teaching the PACT training for frontline workers. So when you recognize the everyday requirements that people need to survive, like food, shelter, income, etc., and how this will influence their ability to access services and have their palliative care needs met, there are many resources in the community of Thunder Bay. And we understand that you may not have the time or ability to help with these specifics, but you can give people pamphlets, point them in the right direction, and connect them with people like me. So since PACT has been in existence, we had started collecting data through our intake process, and I'd like to share some of the findings with you. So the largest group of survey respondents was ages 55 to 64. 73% of respondents identify as Indigenous. 78% of respondents identified as male and 22 as female. 39 live in a shelter or apartment. 55% live in social housing. 6% live in an emergency or long-term shelter. 83 of respondents do not feel that healthcare workers understand their needs. 61% of survey respondents do not feel comfortable talking to healthcare workers about their needs. 9 out of 18 respondents say they do not feel safe where they're currently living. The most prevalent diagnosis for respondents was liver failure. 22% do not have a substitute decision maker, and 15 out of 23 are currently experiencing pain. 100% of survey respondents have transportation challenges. 94% have financial challenges. 73% don't have a phone to make appointments. 94% are unsure of the resources available. 89% say racism and discrimination is a challenge. 83% have had previous bad experiences. 67% feel inferior or less than. 61% have zero tolerance challenges.
Hey, thank you, Julie. So I think that last slide on the barriers to care that clients themselves in Thunder Bay have identified are the areas that we as providers know that we need to work on. So we know that that's a barrier to them accessing the care, and it means those are things that we need to change about our system, because we need to model a version of care that's actually accessible to everyone and equitable. So some of our action items from today, I challenge you all to learn more about trauma and violence-informed care, harm reduction, and culturally safer approaches to care. I challenge you to explore barriers within your own organization to clients accessing care, and challenge you to speak up when you do hear racism and discrimination from your coworkers. You can connect with the PACT team for more education and support, or if you have clients that would benefit from our care. And I challenge you to step outside of your comfort zone. We have some contact information up here if you want to reach out to us. You can also go through, I think May would be able to connect us with you if you want. And our email is on the continuing education handout that we will send out. We'll wait a minute for questions, or should we do questions now? Right?
Yeah, we could do questions. But yes,
Stop sharing so I can see you all.
okay. Thank you very much for that presentation. I have seen it before, and it's just so lovely to watch you guys speak on it every single time. Thank you very much. And I've seen that video several times, and it never fails to make me very emotional. But yes, if you would like to ask our presenters a question, you can either raise your virtual hand and ask yourself, or feel free to put it in the chat. We have a few comments in the chat already. One for Julie that says, thank you for all that you do to support this vulnerable population, with a whole lot of hearts on it. And then we've got another comment from Sue Ray next. She says, thank you so much for this excellent presentation. I agree. I know you. Holly, go ahead.
Hey team, great presentation. I'm wondering if you could speak to the group about some of the challenges that you guys have and continue to experience in terms of not only responding to community needs, but maybe some of those system level challenges that the people on the call could be advocating for within their own organizations or within their own health systems.
Yeah, just starting off strong, Holly. Thank you. Great question. I can start from the kind of the administration perspective, and then let Julie and Natalie have a whack at it from a frontline provider perspective. I think some of the biggest challenges we see come with eligibility criteria for programs. So we added into the survey how many clients perceive a zero tolerance towards drug and alcohol use as a barrier for them. And we had 61% of people say that that is a barrier. And so we know that folks that have been suffering from addiction, that addiction doesn't go away for them just when they have a life-limiting illness. So I challenge you to look at your eligibility criteria for your services and your programs, especially if they are inpatient programs. And if there is a possibility of adopting a harm reduction approach into your care. I think some of the other challenges are, I talked a bit about the barriers or the cracks between the health and the social system. So often we see healthcare providers that want to help with certain things, but it just is outside of their scope or outside of their ability to do, whether that be from organizational policies, time commitments, the HHR crisis that we're all experiencing. I know we're incredibly busy, but being able to step outside of those traditional boundaries, I think is incredibly important. And if there are any managers on your call supporting your frontline workers and being able to step outside of those boundaries, and break down those barriers for them and being able to address needs of their clients. I'll let Julie and Natalie go, and I might think of some more.
So a couple of the challenges that I've noticed just in the last little bit is actually just sometimes finding our clients. So if they're staying at the shelter, like I'm trying to track down this one gentleman, and every time we go there at early in the morning, he's not there and he doesn't have a phone. So trying to actually locate these people to help them. And then also when dealing with these clients, sometimes, as Bill mentioned in the video, they're so focused on survival mode that the healthcare or their healthcare needs kind of go to the wayside, and they're more focused, like I said, just on surviving. So those are two challenges that I can think of. Julie?
I think I wish I could give everyone a cell phone. Like just as simple as being able to call somebody, and like Natalie says, trying to locate people can be challenging. And like as a health organization, having to make that confirmation call to that client that doesn't have a phone, and then canceling their appointment or there's a lot of barriers with just not having a phone. That's huge. I don't know. We just need to house people. We just need people housed and with a phone. And like Brittany says about the zero tolerance, we have a few clients and people that we work with that are just leaving the hospital because they need a fix. They need the fix. They need some wine or they need something. They need more opiates. They're giving them not enough opiates. So that's huge. Like we need to change that, especially in healthcare when people are palliative. Like they're palliative. They have a palliative diagnosis. They're like, why are we so focused on like, it's too high. We can't give them that much opiates, or we, they can't have wine in the hospital. Well, okay, I get that, but also, I don't know. I don't know what the answers are. You guys get paid more. You guys figure it out.
Yeah, Julie, I echo that because I had the opportunity to work briefly in long-term care, and I know that in our city, I believe we have 6 long-term care facilities. We're a relatively small city, about 110,000 people. We serve a larger region. However, in the long-term care home that I was working at, we were the only long-term care home that supported a resident who required methadone. And they only had the resources to support one resident in that entire home. And so, but all of the rest of the long-term care homes could not support anybody who required that sort of harm reduction approach. And so I think of a lot of the clients that I got the opportunity to meet while I was out with Julie and Natalie. And it was clear that some of these clients of yours could use some sort of a long-term care facility or a hospice facility where there is the zero tolerance, where there are no barriers for that type of treatment. And yeah, I don't know what the answers are, Julie, but hopefully we're on the right track with this education. I do have a question in the chat. Nicole says, great work. Is there a national collaboration with other provinces to share information and resources?
Yes, so there is right now, so Healthcare Excellence Canada that we mentioned as our funder for our one dedicated employee to the PACT team, which is Julie, our harm reduction support worker. They have the Improving Equity and Access to Palliative Care Collaborative. So we started as one of the first 10 communities as cohort 1, and they've just added an additional, I think, 13 communities. So there's now 23 across the country. And we have conferences, we have virtual and in person. We have a online platform where we can share resources with each other, and we're working to develop best practices and share them with each other instead of recreating the wheel. Yeah.
Thank you. That was a great question. And we also have some comments in the chat. Jonathan says there's an ongoing study at SMH wherein admitted clients with housing insecurity can be randomized to a homeless navigator. As part of this, the navigator will provide clients with support as they transition out of the hospital, including housing supports, a cell phone, ongoing follow-up, and other essentials. It is such a seemingly simple yet powerful intervention. Yeah, that sounds really great.
Thank you for that, Jonathan. And I do want to mention that if anyone is working within Thunder Bay Regional Health Sciences Center, that there are members of our PACT team within the hospital as well. So you can reach out to 2 of our palliative care physicians, Dr. Zanson and Dr. Selleck, and then Robert Essex, who's the palliative care RN in the hospital. And Robert will actually come to the patient's bed no matter what floor they're on, and he will connect them with the PACT team. So that way when they transition out into community, we make sure that they have somebody like Julie following them and connecting them between the health and social services. So thank you for that.
And Tracy says the goal of palliative approach to care is to maximize quality of life and manage pain and symptoms, and essentially meet people where they are at. This is a holistic and tailored approach. We need to start feeling more comfortable with providing the care and medications that meet the client's needs, even if we think it is outside of the dosages that we are familiar with.
For sure. And to answer Julie's question about how we do that, it's us challenging it both within management and on the front line. Practice changes over time when we develop new best practices, and that always starts with somebody daring to be creative and innovative. And so it really does start with all of us on this call. Thank you for that, Tracy.
Any other questions from the group or comments? If not, we're doing great for time. Did you have any other comments, Brittany, about any of the other questions that I felt like I cut you off there? I'm sorry.
Oh, no, you're good. If you didn't
Okay.
cut me off, we'd go over time.
Okay.
Uh,
Oh, I have
more comment
another
there.
question. And I work for Kingston Home-Based Housing. We work with both unhoused and vulnerable housed individuals. We are fortunate enough to have paired with Kingston Health Science Center, who have developed a palliative care outreach team that comes out to treat those housed and not housed within our population. And there are 0 barriers. That's great to hear that more regions are getting involved. Okay. I'm going to quickly share my screen again. Sorry, I don't know why that's not working. You all see that? Okay, great. So for June, we have a special treat. We have 2 for the price of 1. We have Elder Diane Boots, who is an Indigenous death doula, doing a session entitled Empowering Your Community at the End of Life, developing an Indigenous death doula program, which will take place on June 5th. We also have Age Friendly Thunder Bay with Representative Rebecca Johnson coming to do a session on the organization, how it started, where they are now, and where they're planning to go. It's titled Age Friendly Thunder Bay, Past, Present, and Future. I just want to say a big thank you to our speakers again. It's always a privilege to hear you all speak. Thank you so much. And as stated earlier, when this session ends, you will get a pop-up of the session evaluation, and we would really appreciate it if you could just take a few moments as it helps us out. Thank you again, everyone, and we hope you have a great day. Bye-bye.